the forum back together again. And so we've got a fairly limited run of forums now from today through November the 15th. And then we'll take our winter break over Thanksgiving, Christmas and New Year, and then we'll start up again early in the new year. So just to give people a taste of what we've got, next week, September the 27th, we have the Reverend Demet Jenkins, who is going to be talking about her role with the International African American Museum. On October the 4th, we've got Professor Adam Dombey from the College of Charleston History Department, who recently published a book called The False Cause, which is all about the Confederate memorials and why they probably need to come down. So that's a fairly topical subject. On October the 11th, we have Lauren Rust from the Low Country Marine Mammal Organization, who's going to be talking about dolphins in and around South Carolina. October the 18th, we have Scott Peoples, who's really a specialist in the work of Edgar Allan Poe, but has a sideline in Bob Dylan studies, and he's going to be coming and talking to us about Bob Dylan. October the 25th, we have Margaret Seidler, who's a long-time Carolinian, Charlestonian, I think 7 or 8 generations here in South Carolina, and she was dismayed to learn that she actually has slave traders in her ancestry. And so in the same way that Edward Ball did a book on slaves in the family, looking at his family's history as slave traders and slave owners, Margaret Seidler has done some research and come up with some interesting things about her family. I do not yet have anybody down for November the 1st or the 8th. So if anybody has some suggestions for people to try to round up for November the 1st or the 8th, that would be immediately prior to the election or immediately post-election. So we might need a psychiatrist perhaps on November the 8th, who knows. November the 15th is going to be John Creed from the College of Charleston's Political Science Department. John has done a load of forums. He's a Middle East specialist, and people always love what he does. So that's the run up to November the 15th. The way we're going to run these things, Ren in a minute is just going to introduce our guest for today, who is Shelli Quenga. When Shelli does her talk, or any one of the presenters does their talk, you can put your questions in the chat while the person is talking. Obviously, you can ask questions live at the end as well. But if you put your questions in the chat, I'll be keeping a tally of those things, and I can come up with a list of names and a series, so we know who's going to ask what question when. And I think this actually might work perhaps even more smoothly than it would do in person. So as a speaker mentions something that you're interested in or have queries about, please put it in the chat. I will mark your name down as somebody to ask the question, and then I will unmute you at that point, and you can ask your question in turn. Okay, but in the meantime, I'm going to turn it over to Ren, who will actually introduce our speaker for today.
Thanks, Simon. This was great to have the forums starting up again. As you may know, the Social Justice Committee of our church has started this Herculean effort on trying to move the needle toward Medicaid expansion in South Carolina. And we got to Shelli through Jeffrey Fleming, who is the COO of Palmetto Project, and also through Steve Scarden, who is the father of Sam. We've been working on Sam's campaign for Senate legislative seat 41, and his father Steve is the CEO of Palmetto Project, and so that sort of converged on Shelli Quenga. Shelli is, she oversees the advocacy and programming for the South Carolina-based nonprofit Palmetto Project. She spearheaded the formation of the nation's first statewide nonprofit insurance agency, providing enrollment assistance, insurance, education, and advocacy for South Carolinians with Medicaid, Medicare, and marketplace coverage. She formerly directed a regional nonprofit focused on children with special healthcare needs and continues to serve as a behavioral therapist and advocate for educational, community, and medical services for children with special health care needs and their families. She holds a master's degree from Webster University and a bachelor's degree from Vassar. She and her partner have nearly launched all 5 of their children and happily grandparent 2 of the world's most adorable grandchildren. So Shelli, tell us all about Medicaid and why we need to expand it, and what are the prospects, and what can we do to make this happen?
Sure. So thanks everybody for allowing me to do this morning. So I'm happy to say this is my second time in being a forum presenter. So some of you I may have spoken to when we talked a little bit about the history of healthcare in our country and kind of how we got to where we are. And we were talking a little bit about the possibility of a public option or nationally available healthcare, health insurance for folks. So we're shifting that a little bit to talk specifically about Medicaid and Medicaid expansion in South Carolina. So I think that probably one of the best ways to start is to say that this is an issue that we can agree with the president on, that healthcare is very complicated. And it is certainly extremely complicated because of the way that things are funded. So Medicaid, to start off on a level playing field, I want to make sure that we're all clear about the program that we're talking about. So Medicaid is a jointly funded program between the states and the feds. We are a state that's often referred to as a donee state. So we put in far less in tax dollars to the feds than what we get back from the feds in terms of funding for Medicaid. So typically, as kind of an average, because it does vary by Medicaid type, we put in about 25 cents and the feds give us back 75 cents in terms of funding of the program. Medicaid is generally for people who are low income, children, and people with disabilities. So it differs from Medicare in that Medicare you are entitled to because of your age. When you turn 65, you are automatically eligible for Medicare for 99% of the folks in our country. You are eligible because you've worked 10 years or you've been married to a spouse who's worked 10 years, and so you're eligible for Medicare for that reason. Medicaid has more of a mixture of how people are eligible for the program. So with Medicaid, generally, it is for folks who are low income or who are also disabled. The way the Affordable Care Act was set up, it was really a three-legged stool in order to get everyone covered. And part of that was to expand Medicaid coverage to people who had incomes below a certain level, regardless of whether they were disabled or had young children or were pregnant or were themselves a young child. So it would expand coverage to those who had incomes at the lower end of the spectrum. So a single person with an income below about $16,000 would be eligible for Medicaid. Generally, for most all states, Medicaid is a zero premium program. It is definitely a zero premium program for children. And children in our state then have no premium, no copay, no deductible. So it's a terrific program for kids coverage. For adults, it typically right now only covers very low income seniors. So folks who are above 65 years old, but also have incomes below $13,000 a year. or for women while they're pregnant, or people who are disabled who also have, like a single person under $13,000, they could also get Medicaid if they were under 65 and also disabled. So another way to think about it is that if you are generally healthy and a childless adult, there is no Medicaid coverage for you in the state of South Carolina. So that does include a lot of men primarily, because of course they're not getting pregnant. They are not generally the custodial parents of children under the age of 19. So a huge portion of the uninsured who are not covered by Medicaid are men in our state. And in 2013, when we looked at these numbers, in 2015, when we looked at these numbers, about 54% of the uninsured folks were white men. So it also is a little bit of a breaker of the myth of who is out there uninsured, living uninsured, and needing insurance. It is not a poor Black man, it is a poor white man who is out there uninsured with an income so low. For a lot of folks who are working hourly jobs, they do have incomes under $13,000 a year. I saw one of those questions, like, how can anybody live? And there are folks who do live on that. And those folks then, when they experience a serious illness, they don't have health insurance. And so then it does, more negatively impact their potential to earn income, because they get into this vicious cycle where I'm low income, so I can't get coverage. I'm probably working a part-time job or working as a contractor, so I don't have insurance through an employer. I can't get it from Medicaid. I get sick, I lose income, and then that even further decreases the chance that I'm going to be able to get a job that offers insurance. So you end up in this cycle, but often it's a downward spiral because your income is getting lower and lower because you don't have access to any insurance. And so you can't get healthy enough to get a full-time job that has the kind of coverage that most of us enjoy. So that three-legged stool of the Affordable Care Act, part of that was to expand that coverage. The first court case that went to the Supreme Court did determine that the feds could not force the states to expand Medicaid for this kind of program, that it was in fact optional and states could opt out. So we, along with most of the southern states, opted out of Medicaid expansion. So the only states in the South that have expanded coverage for generally healthy childless adults with incomes under 138% of the federal poverty level are Louisiana and Kentucky. Virginia just expanded last year. Some people consider Oklahoma a southern state. Oklahoma just expanded through a ballot initiative. So you may be wondering why we don't take up, something like that. In South Carolina, we cannot have a citizen-driven ballot initiative. It has to be something that the legislature adds to the ballot, and then it would not be a binding ballot referendum. So it may give us some increased awareness for the state's residents, a better understanding of what Medicaid expansion means, but it would not guarantee that we would expand, even if it were to be added to a ballot referendum, and even if a majority of citizens voted for it. It is not binding, so the legislature would still have to do this. I think it's also helpful for you to know that in 2013 through 2015, when we had a slightly better chance of doing Medicaid expansion with the legislature, we actually had enough votes to pass Medicaid expansion. We had enough votes to even override the governor's veto, because the governor told us that she would definitely veto this. But there was not the political will to override her veto because they were the folks who were in the legislature at the time, did believe Governor Haley then that she would make sure they were never elected again. And their focus was more on re-election and not on getting people covered. They continue to tell us that they do not receive phone calls from people who would be affected by Medicaid expansion, saying that they need Medicaid coverage. This isn't really a surprise to us because, as you might expect, those people in the incomes below 138% of the federal poverty level are also the folks who are typically least involved in politics. They feel disenfranchisement at all kinds of different levels, not the least of which is picking up the phone and feeling like you can have a conversation with a legislator or one of their staff people to explain this very complicated situation. So they know that we as advocates can speak for other people, but they're not getting the calls from the citizens themselves who would be affected by Medicaid expansion. There are very few people who are willing to speak up. You could also understand their perspective. You know, no one is really proud to raise their hand and say, I survive on $10,000 a year and I need this. Because they know that they would be targeted by people saying, well, if you just worked a little harder, if you had done this, if you woulda, coulda, shoulda, you would be making enough money to be able to get coverage. So it's a very difficult position to ask someone to stand up and say, I'm the person who doesn't get coverage. Now, one of the groups that I think is a potential who would come out and be able to speak are self-employed people who are actually on paper not making a lot of money based on their tax return, but in reality are doing fairly well. Because as you know, when you are a self-employed person, your focus is on getting your taxable income down as low as possible because you don't want to pay taxes on that income. So you're looking for deductions everywhere you can get them so that you can lower your tax paying threshold. But it does mean that some people have gotten themselves so low that they don't have a tax burden, but it also means then they are too low income to qualify for coverage in the Affordable Care Act, like Obamacare plans, to actually be able to qualify for tax credits to make that coverage affordable. So these may be folks that are doing services for you already, people who mow your grass, people who cut your hair, people who do your nails, servers who are at restaurants who often get very little to nothing on their paychecks because they're being paid in tips. So those are often the folks who are in the coverage gap, but don't know how the system works well enough in order to get that. I want to show you just one slide that is an income chart because I think this can kind of help you see better where people are falling. So I'm going to share this with you. So let me get to this screen here. This is a chart that we use when we are working with folks because it gives them, it allows us to kind of see where people fit. So this is taxable income. So child support is not included as taxable income. So if folks are just receiving child support, it's not included in here. So when we talk about Obamacare plans through the healthcare.gov, we are looking at this first group of columns over here that says Marketplace Financial Assistance. So right now, as of this year, if a single person is making less than $12,490, are not eligible for any kind of financial assistance to help lower the cost of the monthly premium for their health insurance. So this is at 100% of the federal poverty level. Now, if we expanded Medicaid, that would be for people who had incomes below 138% of the federal poverty level. So there is a little bit of overlap here into when you're eligible for the marketplace, when you're eligible for Medicaid. So this 138% level is what the Affordable Care Act says for Medicaid expansion. So a single person making $17,000 in other states like Louisiana, in Virginia, Kentucky, Arkansas, soon to be Oklahoma, Missouri, if the single person is making less than $17,000 a year, they would be able to get Medicaid with no premium. They do have some small copays in our state for adults who happen to be low enough income to be covered. They have a copay of $3.40 for an office visit or for a prescription. So the way this chart reads, if you're a family of 2 and family size is determined by what is on your tax return, who do you claim as dependents? If there are 3 people on your tax return, then you are a family of 3, and that Medicaid expansion income would be $29,435. Now, maximum income, where you can still get a tax credit from an Obamacare or marketplace plan, then is this 400% column in red. So if your income is above that, then you also are not eligible for any kind of tax credit to help make the cost of your insurance lower. Now, these columns over here in the blue, these are the most common Medicaid coverage categories. Now, some people might be confused because you might hear the name South Carolina Healthy Connections. That is the same as Medicaid. So each state has the option to rebrand their Medicaid program, and many people did rebrand to a different name to help avoid some of the stigma of people going into a doctor's office and the front desk person saying how much, what kind of insurance do you have, and the person having to say, I have Medicaid, instead of being able, they could say, I have Healthy Connections. And so that would disguise it for other people who might be able to hear them when they walk up to the desk, or to perhaps be treated differently by a provider who finds out that they have Medicaid, which pays lower than most private insurances. These are the most common categories of coverage in our state for Medicaid. So as you can see, this parent, caretaker, relative, this is a category of coverage for people who have children in their home under the age of 19. So when you talk about the myth of a welfare mom, somebody who's living off the system, you have to be making pretty low income in order to, quote, live off the system. So a family of 2, that parent would have to have income of less than $10,484 to qualify for Medicaid right now. So it leaves a lot of parents in the coverage gap. So it doesn't offer coverage for most parents because the income level is so incredibly low, and child support is not counted towards this income total. So in addition to white men, we're also talking about a lot of working parents who find themselves stuck between the 62% of the federal poverty level and 100% of the federal poverty level, because they can't Affordable Care Act plans that they can actually afford until they hit this 100%. So there's this gap between 62 and 100 where they also are in the Medicaid coverage gap. Now, pregnant women, so you can have other coverage, and your income can be much higher. And you could be, and actually there is no such thing as pregnant women coverage with a family of 1, because the fetus is counted as a family member, even though they're not on your tax return. So the family of 2 is the lowest that a pregnant woman would be able to qualify for. So if she has income below almost $33,000, she would qualify for pregnant woman coverage. This would cover her during her pregnancy and 2 months after she delivers. This other category of coverage called checkup, this is a super big area of misunderstanding in our state, because people could be eligible for this category called checkup also known as the family planning waiver. They get mailed a Medicaid card, but it doesn't say anywhere on the card that this is restricted coverage. Checkup literally means you are entitled to a physical every 2 years, a pap smear every year, birth control, and all the condoms you would like. And that's it. You don't get any kind of blood pressure medication. You don't get high cholesterol medication. You don't get coverage if you're sick. You only get that preventive screening every couple of years, and you get your pap smear if you're a woman every year. If you're a man, you can also get a vasectomy anytime you would like at any age. But remember, if you're a woman, you don't get to have your tubes tied whenever you want. You have to wait till a certain age when the state believes that you would no longer be at risk of changing your mind and thinking that you want to have a child. Or if you're married, you would have to get your partner's consent in order to get your tubes tied. So this is very limited coverage, but we do run into many people who say, oh, no, I have Medicaid. I got a card. But when we check, or when we talk to them more and find out they don't have young children in their home, they are not pregnant, then we have to educate them on actually you don't have true coverage. You can get a physical and you can get birth control, and that's it. So a lot of people are fooled by this. The biggest category of coverage that we have in terms of numbers of people who are covered are children under the age of 19. So most of the children in our state are covered by Medicaid. You know, our annual, our median income for our state is around, I think, about $47,000 right now. So most of the families in our state have children who would be covered by Medicaid. Even if they choose to cover them by their job-based insurance, they could have Medicaid as a secondary type of coverage. So most of the kids in our state should be covered by Medicaid. Prior to the pandemic, we were at a very high level of coverage for eligible children. We were up to about 96% of eligible children were in fact covered by Medicaid. So we were even a little bit higher than the feds. Their rate is nationally is about 95% of eligible kids are covered. So the Affordable Care Act vastly increased awareness and got many more children covered. We used to not be as good at this. Now there are, though, I think it's important to know, there are 34 different types of Medicaid in South Carolina. So it is a very complicated program. It's difficult for people to know if they're eligible. For certain body parts, you can have coverage. So there is, for example, a breast and cervical cancer type of Medicaid. So if you have lesions, breast or cervical lesions of a certain type, if you have breast cancer and your income is under 194%, you can get Medicaid coverage for those conditions. Now, if you get testicular cancer, sorry, wrong body part, you don't get Medicaid. If you get lung cancer, sorry, wrong body part, you don't get Medicaid. So it has to be the right body parts. This is also how we get most of the nursing home beds in our state covered. So in addition to children, in terms of where those high coverage levels are, in terms of dollars spent, we spend the most Medicaid dollars on people with disabilities, and that includes people in nursing home beds, because you would have to reach a certain disability level and needing a certain level of care in order to need a nursing home bed. So where we spend the most money on Medicaid is actually for people with disabilities and frail elderly seniors in nursing home beds. Medicare does not cover nursing homes. It does not cover your nursing home bed. You have to become eligible for Medicaid or have long-term care insurance, which most of us don't have, or be able to pay out of your pocket in order to get nursing home beds. So many people are not aware of Medicaid's role in paying for nursing home beds. So it is also a great point of education when you hear folks talking about cutting Medicaid. That means cuts to Medicaid nursing home beds and cuts to people with disabilities. So these are our most vulnerable populations that get hurt the most by cuts to Medicaid when you hear about talk of that. So going back then to the expansion discussion. So expanding coverage then would cover these folks under 138% over here in this green column. It would cover those folks who are under 138%. There are a couple of different models that we have looked at. Arkansas and Indiana have what is called their own, like there's an Arkansas model. There is a Medicaid option. So what they did in Arkansas, for example, is they said, okay, anybody who's eligible under the expansion category, we're not actually going to give you Medicaid. Instead, we're going to pay your premiums to buy into a plan through the marketplace. So in some ways, we prefer this option because folks who have incomes under 138% of poverty, their incomes also tend to fluctuate. You know, you pick up an extra part-time job during the holiday season and all of a sudden your income is up. Well, in that case, then Medicaid looks at adult coverage. They look at your income every 3 months. So if your income goes up above 138%, it would kick you out of Medicaid and you'd have to move over to a marketplace plan. If you're always in a marketplace plan, then the coverage to you as the member, as the covered person, would be seamless. I could stay with my same carrier. Just what my cost would be slightly different, based on whether I was covered in the Medicaid expansion category or in a marketplace category. So there's some advantages to that kind of option, like an Arkansas option where they opt into covering people through the marketplace, but just at Medicaid expense. And that was approved by the feds. The Indiana kind of model, we are not as much in favor of. Indiana has a model where they did expand coverage under actually former Governor Pence. When he was governor of Indiana, he agreed to expand Medicaid to folks in Indiana, which kind of boggles the mind when you see how, much he speaks out about not covering folks, but he did it when he was a governor. So in their model, if you have small premiums, and if you fail to pay your premium, you can be kicked out for 6 months, which we don't agree with because that doesn't get folks coverage. And we don't believe that that's the way Medicaid is designed to work. But in the Republican administrations, they have agreed to these kinds of waivers from Medicaid to allow these kinds of programs to kick people out for a period of time and wait for them to come. We have also seen some proposals. We actually saw a proposal like this in our state to make sure that Medicaid members had skin in the game. Okay, I think they're probably losing most of their skin working low-income jobs and working multiple jobs, but they decided that what they should do is they should have like a health savings card, and the individual should put money onto that health savings card, and if they could show that they were putting money on that card, then they would be able to not have a premium. Well, if my income is below $23,000 with a family of 2 and I live in the low country, my rent is a huge portion of my income. As you know, we do not have affordable housing in our area. So even coming up with that premium and our money to put onto a health savings card would be impossible. And then they said, well, anybody could put money onto the health savings card for you. It wouldn't have to be your own money. So we could just find donors who were willing to put money onto other people's health savings cards, as long as they could show that they had skin in the game. And we said, no, we are not willing to make that kind of compromise for people to have, quote, skin in the game. $3.40 of a premium is enough skin in the game when you're making $8 an hour. $3.40 we know is enough to keep people from accessing care. There has been ample research that the federal Medicaid agency has done. The Centers for Medicare and Medicaid Services, the federal agency that is responsible for Medicaid, they have ample research data to show that any type of premium or copay that is added into Medicaid is a deterrent from people seeking care. And we also know from ample research that any type of premium or copay also causes people to not use the service and not be healthy. That we know that the less they go and seek coverage, then the sicker they are, which means the less they can work, which means the less they earn. I mean, it is that cycle all the time. So we are not in favor of any more of a copay than what we have right now in our state. We already have $3.40. We cannot walk that back. That would be impossible. We do not believe that we would be able to get rid of that $3.40 copay, but we don't want any more than that $3.40 copay.
Shelli, can we go to some questions quickly?
Sure, sure.
We need to wrap up by 10:45.
Yeah. Okay.
So Priscilla, you had a question, Kay had a question, and Ren had a question. So Priscilla first, please. Unmute yourself, Priscilla.
Yeah, so Shelli, thank you, first of all, for being with us this morning, trying to explain what to many of us is incredibly complex and such an eye-opener to me to realize that there are so many people that don't get what they need as far as care. But in the very beginning, you said that South Carolina pays, let's say 25 cents and the feds give us back 75 cents. If South Carolina were to pay more, would we get more back from the feds, or is that just the way that the algorithm works?
It's based on the tax dollars that we put in. So most of the states who are in the South put in less than they get back simply because our incomes are lower. So we just don't put in as many tax dollars as other states. We don't have the choice to pay at a higher percentage. So
Okay.
that's not an option.
Kay, your question next. Kay Horn.
Yes, I'm unmuting. My question had to do with who in the world sets these numbers in the first place, and are they adjusted every year in terms of cost of living? I doubt it, but they're so paltry that one would think that Scrooge were the person who sat down creating this table.
Yeah, so the table it's called the Federal Poverty Guidelines has been used for many years and is used for almost all social and work support programs to determine eligibility. So when you hear any kind of statistic talking about people living in poverty, they are generally talking about people under 100% of the Federal Poverty Guideline. So if you live under 100%, then you are considered to be living in poverty. If your income is 138% of the Federal Poverty Guideline, you are not officially designated as being in poverty, even though, you know, it's not a livable wage at all. It's not a livable salary. They are adjusted nearly every year. The only time when they have not been adjusted up was during like the, deep recession. They were not adjusted up, but typically they are adjusted in the fall of the year to go up beginning January 1st. So for example, when we start working on open enrollment for marketplace plans November 1, we will be using an updated chart for the federal program side. Strangely, the Medicaid side of that chart does not get updated until March. So for Medicaid eligibility for the first 3 months of the year, we will be looking at 2020 federal poverty guideline levels. And then beginning in March, we'll start using the 2021 federal poverty guideline levels. So we have to update this chart in March of every year. And then across the board, it's all the same year. But for a few months, it's different. So it does also mean that folks who apply for Medicaid, say in December for January coverage, they might not be eligible. But if they would come back and apply in March, they might be. But Medicaid doesn't tell them that. So we have to keep telling people, keep checking. The rules change. You might be eligible now. Many people had applied for Medicaid pre-Affordable Care Act. Back then, they used to count child support as part of your income. So they applied back then and weren't eligible, so then they never apply again because they think their income is too high. When in fact, we do have families, that are living entirely on child support or entirely on alimony, which is now no longer taxable. So they may be eligible now because they have no taxable income, but we have to keep doing the outreach work to make sure people are aware of changes so that they will come back and try to apply again.
Yes, I see. Thank you very much. And also the process of applying for these kinds of programs is very difficult and time consuming, and taking a day off work, et cetera, I assume.
Yes, so the application, the primary application to apply for Medicaid is 14 pages long.
Oh.
Yeah.
Ren, you're up next with probably what will be the last question, I suspect. Can you unmute?
Oh, been very helpful and overwhelming. We have a project going in the Social Justice Committee to try to tackle this and move the needle a little bit. Obviously, the election is going to change the political landscape, hopefully, and give us options that we don't now have. So the question is, what can we do other than contact legislators and candidates for office to raise the issue with them at this point in time, that you would suggest? And secondly, if anybody, I've put this in the chat, if anybody wants to work with us on this issue, please so note in the chat box and we'll add you to our team. And hopefully things will change in November and there'll be a more likelihood that we will be able to move the needle a little bit. I think one thing, Jim Clyburn in his last coronavirus relief bill that did not get passed was proposing to bring the federal match back to 100%, which would help financially.
Right.
So anyway, Shelli, what's your take on what we could do that would be, a good grassroots step forward?
One of the things that we're always looking for are people to share their stories. So if you have somebody in your family who is uninsured, to encourage them to speak up. We can record their story, audio, video. We can take it down in writing if they're willing to speak to reporters. We need those stories of people who are in the coverage gap. And it's not, I wish we could find a better name for it. It's not really a coverage gap, it's a chasm. It's a place where you go to die. Because without coverage, we all need medical care at some point. So it's really important to find those folks who are uninsured and ask them to share their story. There are a couple of events that the Social Justice Committee is working with us on. So this Thursday at noon on Facebook, on Palmetto Project and South Carolina Appleseed Legal Justice Facebook, we are doing a storyteller spotlight. So that's noon on Thursday. There is a group called Southern States for Medicaid Expansion. And so all of the Southern states who have not expanded are banding together. So we have a storyteller spotlight this Thursday highlighting South Carolina. And then the following Thursday, October 1st, We are doing a digital day of action, encouraging folks to sign a petition for Medicaid expansion, and then each state of the southern states will get that list of names so that we can reach out to those people, and they will be able to join us in this fight. We're also, we really need somebody to do some data crunching for us. None of us, we don't have a healthcare foundation in the state of South Carolina like other states do. So we don't have any kind of nonprofit that is working specifically on healthcare issues alone, that is pulling together the data to show the economic impact of expanding Medicaid. There are a couple of groups in our state who are disproportionately affected by not expanding Medicaid. One of those are folks who are experiencing any kind of substance abuse issue, and another is people who are incarcerated. So mental health issues, substance abuse issues, incarceration, all of that all of that medical care is paid for by pure state dollars because we haven't expanded Medicaid. Because we haven't expanded Medicaid then, and you're only using state dollars, that's why there are limits to the number of people who can seek care, because there's only so much state money. And you're paying 100% of the cost for people who are going to your county medical behavioral health centers. So if they're going to Charleston Dorchester Mental Health and they don't have insurance, that's 100% state dollars that are being used to care for those folks. When if we'd had Medicaid, we would be able to get those folks covered, and 75 cents out of that every dollar of care would be provided by the Fed. So we could get more mental health care to folks if we had Medicaid expansion. That means if we have more folks who can pay for medical care, that means we can get more providers. Because we don't have a lot of behavioral health providers, we don't have a lot of opioid treatment facilities in our state because there is no payer source. So people who need help in those areas, they have to go out of state to get care without insurance. So we send them out of state so that they can live somewhere long enough to be able to qualify for Medicaid so that they can then get help. That's too long of a process for someone who's an opioid addict.
Okay, so Shelli, you and I will be in contact after today to find out, what would be useful, what we can do, and I will send out an email to everybody on this call that puts their name and a contact in the chat box to keep people apprised as to what's happening. And then my guess is after the November elections, we probably will have another Zoom forum to say where we are, look at the landscape, and now what do we do? Because I don't think we can make specific plans now because we don't really know what the political landscape is going to be after the election, and that is the determinative factor on what we should do.
It is.
So,
and there's a part of it that's the presidential election. The other part of it that you're already working on is getting folks elected in Congress, in the legislature, who will vote for these issues.
Right. Okay, so thanks very much. We're
You're
at the
welcome.
end of our time, and hopefully we will have another session when the fog clears and we can see the way forward. But in the meantime, I urge everyone to be in touch with candidates for office to raise the issue, let them know that we're passionate about it, and to ask where they stand on the issue. And then that's probably the best thing that we can do right now.
Thank you, everybody. Thank you very much, Shelli, for explaining this incredibly complicated system in an amazingly clear way. And thanks, Ren, for all you're doing for the church and pushing this agenda. We really need to get it fixed because it's cruel and it's inhumane.
And we'll send out a link to, if anybody wants to view this recording and wants to pass it on to other people who couldn't be with us. I know there were some churches that start at 10 o'clock that couldn't be with us. So we will send out that link.
Thinking I should have told her about this last night. She would have. Thank you all.
All right, that'll be it for today. Thank you very much, folks. I hope everybody enjoys the worship service. Thank you again, Shelli.
Thanks, Shelli.